Welcome to this evening's webinar hosted by Mother and Child Hospital. My name is Temitope Ogunlano and I will be anchoring the session tonight. So I will quickly run through the speaker's profile. And if you haven't yet, you can still invite your friends and family to join us. It's open to the public, it's open to the general public. The link to join the session is in the chat box. You can just forward it to your friends and family. Okay, so as we know, fibroids is a condition that affects many women across not just Nigeria, but Africa and people of Black descent generally. And that's why it's such a crucial topic to talk about tonight. Some housekeeping rules. Please keep yourself muted, except you have something to share. At the end, we will take questions, but in the meantime, while the presenter is speaking, you can drop your questions in the chat box and we'll address them at the end of the session. So please take notes and just keep your questions. We would address them. If you haven't yet, please, you can still invite people. So right now, I'll move on to speak about Dr. Rotimi Adewale. Dr. Rotimi Adewale Stephen is a highly experienced consultant, obstetrician, and gynecologist, currently practicing at Mother and Child Hospital. He is dedicated to providing comprehensive patient-centered care in all aspects of women's health. He has extensive experience in the management of routine and high-risk pregnancies, antenatal and postnatal care, as well as the diagnosis and wide range of treatment of gynecological conditions. His expertise includes performing both major and minor obstetric and gynecological procedures with a strong focus on patient safety and positive outcomes. Dr. Rotimi trained and worked at Obafemi Awolowo University Teaching Hospital Complex Ile-Ife, where he progressed through various roles to become a consultant. During this time, he developed strong clinical, surgical, and leadership skills and actively contributed to the training and supervision of junior doctors. He's committed to the continuous and professional development and remains actively engaged in staying up to date with current medical practices, as you will hear tonight. So please help me give a warm round of applause to Dr. Rotimi Adewale. Thank you very much. So Dr. Rotimi, you can go ahead to share your screen.
All right, good evening, everyone. I want to, first of all, thank you all for joining this meeting this evening. And I also want to thank Mother and Child Hospital for giving me the opportunity to have this presentation. All protocol duly observed, and we don't have much time to start mentioning names for consultants and other senior colleagues who might be part of this presentation. Well, there is no conflict of interest in this presentation, no financial or any form of inducement have been given for this presentation, and is solely sponsored by Mother and Child Hospital. Thank you. So we'll be talking about uterine fibroid, effects on women's health, fertility, prevention, and treatment. And we'll be looking at it under these topics. Why this presentation, why does it matter? Why are we discussing about fibroid? It's important because it's important because fibroid occur in about 70 to 80% of women, and especially by the age of 50. It places higher burden on their head, and they are usually of larger sizes in African women, and Nigeria inclusive. Major causes of heavy bleeding, anemia, and infertility, and it's a major cause of debilitation in women. So what is fibroid? Fibroid are benign growths on the surface or within the uterus. They are benign in the sense that it's a tumor, but they are not a malignant type of cancer. So it's It's a growth that usually occur either within, we can see this intramural, we can see it within the cavity where baby is supposed to stay in the womb, and we can see it also on the surface or on the surface of the womb. So what are fibroids? These have been mentioned. They are not cancerous. They are tumors of uterine muscle. Other names are myomas or leiomyomata. They may be single or multiple, and that they vary in sizes, and it could be as big or as long as 20 centimeters. In some cases, it could, when weighed after removal, it could be as much as 5 kilograms, which I've seen in my practice. Then growth of fibroids is usually influenced by estrogen and progesterone, which are female hormones that are secreted cyclically during a woman's cycle. The types could be submucous, which project into the cavity, and these have highest impact on bleeding and fertility. The cavity of the uterus is where baby is supposed to stay and grow. But when you have something else occupying the space, it becomes very difficult to get pregnant. And this is also where bleeding happens during menses. So there are larger surface area where bleeding occurs, culminating in heavy and prolonged menstrual bleeding. Then we have intramural within the muscle. This is the one, the submucous. This submucous is pedunculated. It's still within the cavity, but it's pedunculated. This is another submucous fibroid. This is subserosa. It's extending from the surface. This pedunculated fibroid. These are the various sizes that we have. Other locations where we could have fibroid include the cervix. That's the entrance to the womb. And it could also be in the broad ligament. That's on the sides of the uterus. How does fibroid affect a woman's health? The common symptoms are usually heavy bleeding, especially for fibroid within the cavity, or those that have extended due to their large sizes into the cavity, or those that have caused some distortion in the endometrial cavity. So this can result in heavy menstrual bleeding. It could cause swelling. It could, especially in very big cases, long-standing cases, which can be cosmetically embarrassing. So the tummy is already, the abdomen is already big, and most women, when they are walking around, people are in the community will already be calling them pregnant women. Some will be called Mama Beji. Meanwhile, they are not pregnant, which is very embarrassing and distressing for such women. Then, due to the size, it causes some compression, because especially on the bladder is where urine is stored before urination. But because of the proximity of bladder to the uterus, when the fibroid gets to a certain size, it begins to compress on the bladder, reducing the bladder capacity. Such women will have to run to toilet to urinate more often than expected. And then it could also cause some compression on the rectum, which is directly behind the womb, and this can cause constipation. Because of the size, it causes pelvic pressure, and this can cause pain. There can be torsion, especially for the pedunculated fibroid, as if it's twisting on itself, which shut down blood supply to the fibroid, culminating in serious acute abdominal pain. It causes some indigestion, bloating, and it could cause also painful menstruation, and it could cause infertility. So these have been described, and so these are the complications. Cause iron deficiency anemia, especially from bleeding. Reduce the quality of life and productivity of a woman. A woman who has been bleeding for days may not be able to focus. Some may not be able to go. They will have to think about the type of clothes they will have to wear. They will have to look for other things to make them comfortable at work because of the heavy bleeding that they may be having. Some even don't bleed. They have this continuous foul-smelling vaginal discharge, which may happen especially following their prolonged period. All this reduce the quality of a woman's life and then their productivity. Acute pain in cases of degeneration, especially in pregnancy, then torsion of pedunculated fibroid. These are possible complications of fibroid. So how does fibroid affect fertility and pregnancy? This diagram shows the various ways fibroid can affect women's fertility. When we are going through medical school, we are told that fibroid is not an established cause of infertility because there are women who have even very big and giant fibroid and they still get pregnant. If I saw when the baby are delivered, the fibroid is usually larger than even the baby. So in what way does fibroid now affect pregnancy? So it causes uterine distortion. When it causes uterine distortion, when it causes uterine cavity distortion, like I've said earlier, this is where baby are stayed. I mean, the fetal growth or the implantation of the embryo is in the uterus, and this is where it continues to grow till maturity. Now, if fibroid is already within the cavity, there's no way the fetus will be able to grow. Impaired endometrial and myometrial blood supply may cause compression, reducing blood flow to the uterus, increase contractility and uterine contractility. And we have molecular changes in cytokines and the interleukins, which toxic to the developing embryo, impair endometrial receptivity and gene expression. These are things that affect fertility and conception with fibroid. So the structure of the endometrial cavity, if you have a fibroid within the cavity, it may be difficult to for the embryo to implant uterine contractility, and this can cause early miscarriage. Apart from preventing pregnancy, may also cause pregnancy wastage. So you can see this case is a fibroid at the cornua end, which invariably will block the tube. So when a woman successfully gets pregnant with fibroid, what can happen? Can cause preterm labor, can cause abnormal presentation. Placenta problems can cause placenta previa. In some cases, where there are maybe bleeding from the placenta abnormality, then you have antepartum hemorrhages. Then after delivery, because of the distorted or dysfunctional uterine contractility, such women may have postpartum hemorrhage, that is bleeding after delivery. So what are the risk factors? These are women with very big and giant fibroid, which is even bigger than term pregnancy. So what are the risk factors? Well, African ancestry has been implicated as a major risk factor. So Black American, Black African, women are predisposed to fibroid. And the risk have been said to be about 3 to 9 times higher than that of the Caucasians. Then family history, first-degree relative, the mother has it, then most likely the daughter will have it. The first-degree relatives, sisters, and other siblings, female sibling, are risk factor with fibroid, are risk factor for uterine fibroid. Early menarche, like you said, the growth of fibroid is highly potentiated by hormones such as estrogen and progesterone. So early exposure to these hormones by early menarche will culminate eventually in the development of fibroid. Nulliparity, long period of getting pregnant. You know, we have women nowadays, there is delay, most of the time, delay marriage, delay conception, infertility. So all these are potential risk factor for uterine fibroid. So obesity, hypertension. This obesity is a risk factor because increased adipose tissue lead to increased exogenous production of estrogen, which invariably fuel the growth of fibroid. Then we have vitamin D deficiency, which has been implicated from environmental study. So how do we prevent reduce the risk of fibroid? By maintaining healthy weight and by doing regular exercise. Weight reduction is an important way of preventing the growth of fibroid. Diet, high fiber diet such as in nuts, fruits, vegetables, reduce the incidence of fibroid, and reduction in the intake of red meat and fatty diet actually reduce the risk of fibroid growth and progression. Correction of vitamin D deficiency where present is also necessary for the prevention of pregnancy, and this can be corrected by using vitamin D supplements. Early evaluation of symptoms. Why fibroid becomes more like a burden for most African women because of late presentation and the fact that most women usually take a long time before coming to the hospital. And we've seen patients with fibroid as big or as huge as a 30-week pregnancy. And then they will say they never knew something was there. Something maybe is a sign of good living that their abdomen was getting bigger, but they will never seek medical treatment or evaluation until symptoms begin to set in, such as heavy menstrual bleeding. Even some, it's until when they are ready to get pregnant. Maybe they've been trying, they could not get pregnant. They just say, "Oh, let me do a scan or let me do something." That's when it will be detected. So early evaluation of symptoms, especially in patients with risk factor, maybe family history or obese patients. So early evaluation is an important way of preventing the growth and proliferation of fibroid. So how do we treat fibroids? We do from history of abdominal swelling or symptoms such as heavy menstrual bleeding, constipation, infertility, or difficulty getting pregnant, the early telltale sign that may result in further examination, such as pelvic examination, ultrasound study. Ultrasound has actually revolutionized the diagnosis of fibroids and is now everywhere. So it makes the diagnosis very easy, even in remote parts of sub-Saharan Africa. So is the most of the time is the first go-to investigation to confirm the presence of fibroid in the woman's uterus. Hysteroscopy, which has been around for a long time and is being popularized currently, is an important way of diagnosing submucous fibroid, that is fibroid that resides within the womb, within the uterine cavity. Laparoscopy is also one of the gold standard methods for diagnosing fibroid, especially for submucous, for subserous and pedunculated fibroid. Then we have MRI, which are mostly indicated for further studies to map and to determine the size and location of the different fibroid nodules, and also the relationship to contiguous structures, especially the ureter, the kidneys, which the uterus might impair their function, especially in cases where the fibroid is very big. And also in some cases where the diagnosis is in doubt, especially to confirm malignancy. It may also be magnetic resonance imaging comes in handy in confirming the diagnosis of uterine fibroid. So how do we treat? What are the options that we have? Well, so we have expectant, that is, we are not doing anything. We're just waiting to see how it will progress. In some cases of fibroid, we tell a patient, oh, madam, this fibroid is still small, or this fibroid does not have any potential for causing any problem at the time of evaluation. And if such women have not been pregnant, you tell them, oh, you can do well to try and get pregnant as soon as possible to prevent the growth and progression of the fibroid. That is the expectant management. Then we now have conservative management. That is, we are doing something to alleviate mostly the symptoms and to also treat some other condition that may be associated with the fibroid. In this case, we use medications. We also have conservative surgical approach in terms of surgical removal of the fibroid. So myomectomy, which is the removal of fibroid, can be done minimally by minimally invasive approach, and it can also be done through open surgery. Then we have other newer methods such as the MRI focused ultrasound and thermal ablation, uterine artery embolization. Then the ultimate treatment is the radical approach, which is by removing the womb. So the principle of treatment include individualization of the patient, and this involves the age of the patient, the symptoms the patient has, the size and location of the fibroid, and the fertility desire. In this case, you have to consider the age of the woman. A woman who is maybe in his 20s has fertility desire. The fibroid are big and causing some other symptoms. So the best treatment approach for this patient is to either consider other methods such as the minimally invasive surgery, such as hysteroscopy, when indicated, laparoscopic approach. Then you can also use the other methods such as the high frequency, high intensity focused ultrasound treatment, or other non-invasive approach such as the uterine artery embolization. A woman is in her 30s and she has fertility she has fertility desire, fibroid is causing problem. We can remove the fibroid either through open myomectomy or through laparoscopic option. I've talked about the expectant management, and the goal of the treatment is to control symptoms, improve the quality of life in terms of bleeding, pain control, and to preserve the fertility of the patient where desired. So the medical treatment, what does it do? Control bleeding, especially in patients with heavy menstrual bleeding, pain, and in some cases may shrink the fibroid temporarily. Often used as bridge to surgery or for symptom control. As some patients with very big fibroid, we want to give them some drugs to shrink or reduce the size of the fibroids so as to make the surgery easier and to prevent other complications such as bleeding during the surgery. So you give them such drug for a period of 2 to 3 months, and then the surgery can be done. Or patients who are not fit for surgery, you want to buy time, they have lost so much blood, and then you need them to regain, to build some blood level before the surgery, then you can give them some drug. It's important to know that when giving, during medical treatment, recurrence are common after stopping the therapy. Medical option, we have the hormonal, can be in the form of combined oral contraceptive pill, progestogens. Then you have the levonorgestrel intrauterine system. So these are drugs, these are medical hormonal treatments. Then we have the GnRH analogs in form of liprolytes. These are short-term causes for short-term shrinkage. It's important to know that this drug's use is highly restrictive because you cannot give it for long, especially for GnRH analog. You can't give it for more than 6 months. And if given for more than that period, especially for women who are not postmenopausal, it has postmenopausal side effects. And this can have other adverse effects on the patient. So it's not given for long. So because some patients see it as a safe haven as an alternative to surgery. It's just there to manage the condition for the short-term period, especially patients who are going for surgery. Then good for patients who are close to menopause. You want to buy time for them until they eventually get to menopause. So, or you want to relieve some of the symptoms, bleeding and pain. So these patients may benefit from the GnRH analog. Then it's important to note this drug has side effects, which I've mentioned. And then in patients on progestogens, we have heavy weight gain and irregular bleeding. Well, the other drugs which have also revolutionized the management of fibroids, especially in cases of heavy bleeding, either during surgery or before surgery, is tranexamic acid, which are antifibrinolytic agents that have been pivotal in preventing or reducing blood loss during menses, especially for patients with heavy menstrual fluid due to fibroids. So very important. NSAID, which is a non-steroidal anti-inflammatory drugs, are also good for pain control and reduction of blood loss. Mammectomy, which is a fertility-preserving surgery, removes fibroid and keeps the uterus. The routes of surgery include hysteroscopic, especially when the fibroid is within the cavity. Then it could be laparoscopically done when, especially when carefully selected patients, because some of our fibroids may not be suitable for laparoscopic surgery. Then we have it in open surgery, where we have to open, bring out the womb and then remove the fibroid. The benefit of this approach improves symptoms, improve fertility in selected cases. So most patients, especially with fertility problems, get pregnant shortly after removal of fibroid. The risk include bleeding, then there may be addition formation and recurrence in up to 15 to 30% of cases. And there's usually a disclaimer for patients going for this kind of surgery of the potential of reoccurrence, especially when there's a long gap between the surgery and conception. And especially for the first 1 year after surgery, the risk of recurrence is about 5 to 15%. And this may near about 50% in about 5 years post-surgery. And this increased to about 80% about 8 years post-surgery. So women are actually advised to be sure that they are ready to get pregnant as soon as possible, because pregnancy have been seen to prevent the growth and progression of fibroids. So it's important for women going for surgery to be ready to get pregnant as soon as possible to prevent recurrence. And this is another approach which is minimally invasive. Uterine artery embolization. You can see the artery supplying the uterus are blocked through a radiological approach. There's a catheter that is passed through the vessel, actually the femoral artery, and then the agents are injected to block the artery supplying the uterus. So this invariably will reduce blood flow to the uterus, and then the fibroid begin to shrink. So it's The risk of pain post-procedure is there. Infection is possible, especially in cases of large fibroid, and then it may affect ovarian reserve, especially because it may have effect on the supply to the blood supply to the ovaries. So hysterectomy is the definitive treatment that removes the uterus and cures the fibroid permanently. So it's the only treatment that can make a woman go for surgery and then go to sleep without having fear of recurrence of fibroid. It's indicated for severe symptoms and completed, and in cases where the woman has completed family size. Approaches include abdominal, laparoscopic, and it can be done through the vagina. Risk of surgical risk is there, the loss of fertility, and then the psychological impact of having lost the uterus is there. So we have this is a normal. So we can see the before and after the removal of the uterus. So newer fibroid treatment, some of these have been mentioned. Focus on uterus preservation, minimally invasive, may also be non-invasive, faster recovery and less pain, and these are alternatives to open surgery. So the oral GnRH analog, there are newer drugs now, because for the GnRH analog that we have, the leuprolides, are mostly given via subcutaneous route, like an injection on the skin, under the skin. A patient has to come every month to take the injection, where we have extended preparation for up to 3 months. So, but these newer drugs, they are given orally, that the woman continue to take it every day. This has the same effect as the injections. And then women are also given add-back therapy. Like I said before, some of these drugs, when taken for a prolonged period, may induce menopausal symptoms, but other drugs are given to reverse the menopausal side effects. Then we have selective progesterone receptors and modulators, and this leprostar have been shown to shrink fibroids, but there is limited use due to its effect on causing liver toxicity. Then we have minimally invasive procedures, radiofrequency ablation, and then in form of sonata. These are newer methods that have been done. There's no incision. There's a probe that is inserted through the vagina, and then it goes from the cervix into the fibroid. The fibroid is seen, and then the energy is delivered through the cervix. Then we have this other one, Assessor, is still the same as sonata, but laparoscopically done. They ensure quick patient recovery and their outpatient procedure. The focus ultrasound, which uses sound wave to destroy fibroid. There are no incisions. Trying fibroid embolization, which has also been mentioned, shrink fibroid by blocking blood supply. There are emerging and experimental treatment, collagenase injection, because fibroid are mostly made of collagens. Agents that break down such tissue are injected into the fibroid and to cause breakdown over time. Green tea extracts have been shown to slow the growth of fibroids. Also have vitamin D supplementation has potential role in the prevention of fibroid. So, however, more research are still needed, especially from our environment, in the prevention and the cure of fibroid. So, these are how do we choose the right option for the patient? The patient factor. Does the patient have desire for pregnancy, the size and location of the fibroid, and the number, severity of symptoms, and then previous treatment? These are factors from the patient that will determine the type of treatment that the patient will benefit from. Then the system and the clinical factor, medical versus surgical suitability is an important factor, because unstable patients may have far-reaching complications if taken for surgery. Availability of minimally invasive options. If these are available, and this is becoming very popular in our environment now, we have laparoscopic myomectomy, which are done with minimal or no incision, and then we have hysteroscopy, which can remove fibroid within the uterus without having to cut. Then the cost and access to treatment. Cost has been a major factor in some women assessing treatment for their fibroid. And then the patient's preference after counseling. There are many patients who come to clinic and they have strong indication for fibroid removal, but they would still decide to do otherwise due to their own personal preferences. So what are the red flags and misinformations about fibroid? Fibroids are not cancers. They rarely have malignant potential, and that's in less than 1%. Pregnancy is still possible in many women. The claim that there are drugs, wonder drugs that will cure fibroid, and the woman will go to sleep is baseless. So there's no treatment or drugs that the woman will take that will completely obliterate or take away fibroid. I'm sure many women have been scammed or currently being scammed because of this belief. You know, I've seen patients who have been canceled for surgery, then they for 3 months you won't see them. And they come back with other problems, such as gynecomastia, and because they have tried some herbal means, they're giving them some drug to insert into the vagina, and they claim that something will fall down, take away, and that's the fibroid. But they come back, they do scan, they will still see fibroid. And now they have developed other problems. The vagina is totally closed because of the drugs or the herbal medication that they have been given. So, and there are brands also who are actively marketing herbal drugs, claiming that they can treat fibroid. These are lies and baseless. They are not true. So when should a woman seek care for fibroid? When there are symptoms such as heavy bleeding, and in some cases, passage of clots. In patients with severe or persistent pelvic pain, and in cases where the fibroid becomes very big, some women will find it very difficult to breathe. They can't eat much. Once they eat, then they have early satiety. And even some causes some embarrassment in the community. They say, she's pregnant. Remember, said somebody that I was told of somebody who was said to have been pregnant for 14 years, was carrying pregnancy. Everybody in the community thought she was pregnant, and it's some village people that have tied the baby in her. Meanwhile, she had fibroid. So until she went for surgery, eventually got pregnant and had a baby. So these are when the fibroid becomes very big, it's important to remove it, irrespective of other considerations. Difficulty getting pregnant. After all due investigations and trials, a woman does not get pregnant, then there may be with fibroid, then there may be need for fibroid removal. And in cases where there is rapid enlargement, which I've mentioned, very big, huge fibroid, there is need for removal. The key takeaways from this presentation that fibroids are common and manageable. They are very treatable, and women should seek help on time. Early diagnosis prevents complication. There are multiple and effective treatment options that we have currently. Thank you.
Thank you so much, Dr. Rotimi. That was fantastic. Please let's appreciate
Yeah, we're
him
done.
in the
Thank you.
chat. Okay, I think you can hear me. I was speaking. Can everyone hear me? Okay.
Yes, we
Thank
can.
you so much. Okay, thank you very much. So, like I said at the beginning, we'll take our questions now. We have a number of them in the chat, but if anybody wants to ask your question in person, you can raise your hand and we will unmute you and you can ask. And it would also be nice if you can turn on your video if you're asking a question. But if you're not in a place where you can, that's okay. We'll still take your question. So, Doctor, as you were speaking, a couple of things came to mind. I wanted to know if, first of all, if we're seeing an increase in fibroid cases, or that's not the case, because it seems like we have so many other methods than in the past to treat it. So, what's the issue? Is it that it's reducing? Should we be happy that it's reducing, or is it actually increasing in society?
Okay, do you want me to respond now?
Yes, please. You can respond to that.
Okay, so generally, it seems like there's an increased incidence of fibroid. One, because we have better methods of diagnosis. Now we have ultrasound, which is ubiquitous. You see it everywhere, every nook and cranny, even in local communities. You see it. So there's no hide and seek. Then, even if scan does not pick fibroid, we have other methods such as MR, magnetic resonance imaging. Then, even the tiniest of fibroid can be diagnosed with hysteroscopy. You know, the fibroid that is within the womb. Other areas of the uterus may seem normal, but the woman continues to bleed. Then you just say, oh, let's do hysteroscopy. Then hysteroscopy will locate it. So these are things that makes it look like, oh, we're having higher incidence. And now also, I don't know, maybe because of the pursuit of happiness, many people, men and women, wants to be somebody, like you want to get to a certain level in your career, everybody is pursuing, you want to, just make an headway. So a lot of women delay marriage, and even some get married, then they delay conception, pregnancy. So these are other factors that are increasing the incidence, because the woman stays all along. Most women over 30 are not married or not pregnant. Then definitely most of the time they will have fibroid. And these are other factors that are increasing the incidence. So I would say generally there is increasing incidence of fibroid because we have better method of diagnosis. It's no longer hide and seek. Then most women delay marriage and conception. So these are factors that may contribute to the increase.
Okay, so we've also heard of because of fibroids and ovarian cysts are around the reproductive organs of women. Is it possible for the two to be mistaken? And then we've also heard some people say that birth control methods may or may not help or even contribute to fibroids. What do you say about that? And then finally, does fibroid have anything to do with PCOS or endometriosis? Before we take the other questions, sir. Should I repeat that?
Okay, let me take the last one first. I didn't quite get the first one. Well, okay, so fibroid and PCOS are related because they are part of the metabolic syndrome. When you look at metabolic syndrome, it's a constellation of conditions that when you see one, you look for the other. And that's when we have obesity, have hypertension, then PCOS has also been linked to the metabolic syndrome because one of the risk factors is obesity. So women who have all these endometriosis is another entity from PCOS. But all these PCOS will delay conception. Endometriosis may damage the tube, damage the other reproductive, the milieu for reproduction. And then the woman will not be able to get pregnant. Then the risk of fibroid growing. So that is the link. So they are interwoven because of the for PCOS, because of the metabolic syndrome. And we also note that obesity is one of the risk factors for fibroid. So that is the link. Then the first question, I think you are talking about contraceptive pills. You mean birth control
planning
pills.
Yeah, does it?
Yes, family planning may have a role because, like we said in the earlier part of the presentation, that the hormones of menstruation, the estrogen and progesterone, the cyclical release, continuous release without break, you understand, is what potentiates the growth of fibroid. Or if you are taking any agents that will either reduce or stop the natural production of these hormones, especially estrogen, then it may have a way in reducing the incidence of fibroid. And some of these drugs have also been very useful in the control of symptoms of fibroid. So in a way, they are very useful in the management of fibroids. Drugs such as the progestin are actually very useful in the treatment of fibroid. Contraceptive pills have also been used and in controlling symptoms, and also for a prolonged use can also help in shrinking the fibroid.
Thank you, sir. So I also asked if it's possible to mistake a fibroid for an ovarian cyst.
Hello?
Can you hear me?
Okay, please come again.
I asked if it's possible to mistake a fibroid for an ovarian cyst or for a cyst.
Okay, so looking at the anatomy, fibroids are growth either on the surface, within the uterus, or within the cavity. So I want to show, you can see, become very clear. Okay, so this is the uterus, this is the ovary. I don't know if you can see the console, but so
Yes,
the
yes.
ovary is actually different from the womb, which is the uterus. So they are different anatomical entities, though they are very close. Then, in some cases of pedunculated fibroid, where the fibroid is attached to the surface of the uterus, especially like this one now, you can see it's like dangling. So it can bring confusion, especially on scan, on ultrasound. Some may confuse it with the ovary and vice versa. So they may think, oh, this is the ovary, this is the this is the fibroid. So because of the resemblance in their presentation, in fact, some cases of torsion of fibroid, of pedunculated fibroid, could be mistaken for ovarian torsion. So that is the only case where that confusion can arise. But on the normal presentation, the fibroid and the ovaries are clear anatomical entities. So that is that.
Thank you very much, sir. Okay, so I think we're now going to move to the questions in the chats, and there are quite a number. So you already sort of spoke to one of the questions. The woman was asking that her mom was diagnosed with a fibroid, and it's been years. It has grown big, and she's scared of surgery. A Neolife drug company sold her several drugs, promising to shrink it completely in a month. Will this work?
All
And then
right, so I
because
think
of
I've
this,
addressed some
because
of
her
this
mom has it.
in the earlier part of the presentation. Well, these are more like a mirage because it's a false hope. I mean, if anybody comes and say, "Oh, this thing will go by taking a drug in 1 month," I think that says it all. You know, there's no drug medically that will shrink the fibroid and everything will go, you know, in 1 month or in any foreseeable time. So there is no particular drug now that will melt and completely disintegrate or make the fibroid to disappear. And I must say that I've had patients who have had similar experiences. So you tell them, oh, do you need to do surgery to remove fibroid, especially very big fibroid. And then they go away for 3 months, and these patients are patients that you have invested in their treatment. You've been concerned about their symptoms, then you just will not see them again. Either because of the cost or the fear of surgery, then they go and meet these people. And they promise them, oh, it will go, it will go. They had a patient like that, went for like 3 months, spent more than double the money for surgery. She eventually came back. There was one that had something inside. They gave her something more like herbal preparation to insert into the vagina. By the time she came back, she could no longer have intercourse because the vagina is totally closed. I see as somebody that came quite a few weeks ago with similar problem. So it's more like it's more like a waste of time and waste of resources, and then it cause other serious complications. So I won't say, but that's my own perspective about such drugs based on the experience I've had with them. So I know
thank you for the
claims
answer.
of total removal of fibroid using herbal preparation or any form of drugs.
Okay. Another question is, what do we call heavy menstrual bleedings? I have fibroids, always have since 2013. My menses have gone from 5 days to 7 days to 3 days. Is this heavy bleeding?
Please come again. There was a break in network.
We call heavy bleeding. I have fibroids, always have since 2013. My menses have gone from 5 days to 7 days to 3 days. Is this heavy bleeding?
Okay, so well, the normal period, the expected period for menstrual bleeding, usually 3 to 7 days, which is normal. Well, at any time when it's more than 7 days, then we call it menorrhagia or heavy menstrual bleeding. So that becomes abnormal. But then it may still be within the stipulated period or the expected period. But then if it's heavy in the sense that you are using more pads, or you are using more pads than usual, than the one you used to use before. You are using 2 before, you are now using 4. You are now changing it 3 to 5 times per day. You are going to work. You have to take extra pads with you, thinking that, you may have to change multiple times. So that becomes heavy. Any bleeding or menstrual bleeding that have effect on your quality of life, then is becoming abnormal. Then any bleeding that has effect, or that cause hemodynamic instability, you started feeling weak, every time during your period, you're always very weak. You feel dizzy. Somebody was, I was called that one patient collapsed in the market, a few days ago, because it may be fibroid. She had been bleeding from fibroid, then becoming very heavy, then she fainted. So any bleeding, any amount of bleeding that causes hemodynamic instability, then is already abnormal. So irrespective of either the duration or the way the blood is coming. So that is what you need to know. So if you are using more pad, if the length is more than 7 days, then if it causes any hemodynamic instability, then it's abnormal. Thank you. Hello? Am I still on?
Yes, we can hear you.
Okay, thank you.
Can hear you, sir.
Okay, so there's a question. If doctors are suggesting surgery, even though it's not that big, but there are multiple, as you said, if someone is not ready to conceive, she should not go for the surgery. Not being ready to conceive. Okay, so from this question, where there are times that doctors will tell the patient, oh, madam, this fibroid is asymptomatic. It's not causing any problem. It doesn't affect your quality of life. The period is not heavy, no pain, and it's not big. Even though there may be multiple small nodules, then if you are told not to remove it, then it means that, okay, there's no problem at the moment. well, you may be advised to get pregnant get pregnant as soon as possible or get married if not, so that it will reduce the progression, the growth. So that's what is expected. But in any case, when fibroid becomes a problem, even if it's very tiny, especially submucous fibroid, there's heavy bleeding. Every month you have to come to the hospital for blood transfusion, then it has to be removed, even if you are not ready to get married in 10 years. So at any time it becomes a problem, then it needs to be removed, irrespective of either you are ready to get pregnant or not. Thank you.
Okay, another question is, can you please confirm?
Hello? I can't hear her. Okay, so there's this question also, can fibroid removal be done with surgery, CS surgery? Well, this is usually not advisable. In the early days when it came in, when it was in vogue, many surgeons were very eager to remove fibroid during surgery, during CS. But a lot of people got burnt. Then people started, withdrawing from doing such surgery. Well, the risk is because pregnant uterus is different from a non-pregnant uterus. Pregnant uterus has more propensity or ability to bleed more. And removing fibroid during this time may have very more serious complications. So that's why people have started moving away from it. But then there are instances where you have to remove as a surgeon, especially if it's on the way, where you want to make incision to deliver the baby. That's where the fibroid is. So you have to remove it. Then if it makes delivery technically difficult, there are times when the fibroid is so big, it's even lying on the baby. So you have to remove the fibroid. Then if it's pedunculated, it's just dangling. It's dangling there. There is something you can just tie and then remove. Fine. Then you can remove it because it may also cause some problems after delivery. So these are instances where fibroid can be removed during during cesarean section. But it's not to say, oh, I have fibroid, I'm going for CS. Thank God, it will be removed. No, that's not the standard as of now. Thank you. So fibroid regrow, the recurrence after surgery is very, very possible. And I've said that in about 5 to 15% of cases, the regrowth starts even after 1 year after surgery. And it may near up to 50% 5 years post-surgery. So fibroid can regrow, especially when conception is remote. A patient is married, have been trying to get pregnant, is not coming, then fibroid can regrow. And the reason they have been put forward for this because there are some micro fibroid nodules during the surgery that may not be able to remove. You may not even see it because they are so tiny. But the moment you repair, everything heals back, then start to grow. And this is common, especially with laparoscopic surgery, laparoscopic myomectomy. The risk of recurrence is higher than open surgery because you're not there to use your hand to palpate, to see if there are very tiny ones. You can't do that with laparoscopy. So that's why the risk of recurrence is higher with laparoscopic myomectomy than open myomectomy. So painful menses on the first 3 days alone or 5 days cycle that affect daily life activities is normal. Well, there are other causes of painful menstruation apart from fibroids. So there may be need for further evaluation. Okay, so if a patient has fibroid, is small, and it has not started causing a problem, the person is not ready to get pregnant, and you can just monitor over time, like the expectant management. Then there are some drugs now that have vitamin D and other supplements that research has shown may help. You can take vitamin D supplementation, which may reduce the growth of the fibroid, and such drug can also be used. Okay, the procedure, the non-invasive or minimally invasive procedure are not for all patients because there is need for good case selection for such surgery. Even the high intensity focused ultrasound, the HIFU, is not for all patients, but I had an interaction with the center that is offering such services because I had a patient who went there. Patient went there with very big fibroid. I mean, the fibroid was so big that even after the procedure, they were the one giving her Soladex, giving her Lipodex after surgery, repeated surgery and all that. And I had to let them know that, okay, there was no good selection because there are criteria, the size of the fibroid, the location, and even the fertility desire of the patient should also be taken into consideration for such procedure. So not all patients can go for minimally invasive or conservative, non-invasive approach. So it has to be carefully selected. Okay, so this person is 51 and have been diagnosed with multiple fibroid. In early menopause, is it advisable to opt for surgery, or what is the best? So it depends on the symptoms. Usually, it's believed that after menopause, fibroid begins to regress. Some symptoms such as heavy menstrual bleeding, because menopause are setting, there's no longer bleeding. So that will resolve automatically. Pain of menses will also resolve. But in cases of very big fibroid, that's embarrassing in terms of the size and all that. It may take a longer time to say you want to wait for everything. To resolve. And we also have risk of malignancy. In the animal
Hey, is someone still speaking? I cannot hear Doc again.
Please give us a few minutes. He will rejoin. He had, I think, network train out, but he will rejoin shortly. We're still here. Okay, we have some other medical professionals in the house while we're waiting for Dr. Rotimi to come on board. Dr. Tony, are you able to speak? Matron Adeshino, are you also able to speak? Dr. Tony, if you're able to speak, please. I also think I see Dr. Familusi. So if any of you can help us with the questions, we would really appreciate it. Dr. Familusi, can you speak, please?
Okay, thank you. Good evening. And good evening, everyone.
Good evening.
Yeah, I hope I'm audible.
Okay. Yes, you're audible, sir.
Okay, I'll
So
just
did
stand
you
into
hear?
it.
Okay, sorry, I was logged out.
Okay, I think he's back now. Thank you very much, sir. Dr. Familisi was just about to help us answer some questions, but yeah, we're glad to have you back.
Okay, thank you.
So please, you can take up from where you stopped.
Hello? You?
Hello, sir. You can go ahead to continue answering the question you were answering.
Okay, I don't know which one I've been.
Okay, so let me just move to some that we have not answered then. Okay, so somebody says she was diagnosed with 2-centimeter fibroid last year. She checked last month and it has grown to 3.2 centimeter. Although she's still asymptomatic, but it is increasing. She doesn't know how to manage the growth.
Okay, so for 2-centimeter fibroid, especially if it's one, and well, it's not big, it's not that big, it wasn't that big at the time. But looking at it over time, over a year, it has increased to 3.2 centimeters. So meaning there is progressive growth. And with increasing growth, it may begin to cause some symptoms. And such symptoms are pain, which you should describe as sharp pain. Then there are other things that need to be looked into, like the size of the fibroid, the location of the fibroid, where it is, to be able to know how, and what to do about it. But 3.2, if it's just a single fibroid, it's just to, except for the pain, you can just maybe take some supplements or some pain control drugs, especially when the pain happens. But if it's pedunculated, it be due to torsion, as if it's twisting, and this may cause some pain. And when there's degeneration as well, degeneration may cause some pain.
Okay, sir. So somebody said, is UFE an option if you still want to conceive in the future? She's 27.
Sorry, I didn't hear that.
Is UFE an option if someone wants to still conceive in the future? They are 27 years old. UFE, that's what she wrote here.
Yes,
Maybe
yes.
Okay.
Okay, so you try and have fibroid, you try fibroid embolization, that's what it means. So, but embolization can be done. Like I said, you have to also take into consideration the location and size of the fibroid. So that's a minimally invasive approach to the treatment of fibroid. And at that age, if you are not ready, that's a good treatment option, especially for smaller fibroid nodules. So fibroid can return after surgery. That's been emphasized. It can return after surgery, and any surgeon performing mammectomy, either open or laparoscopically, will do well by telling the patient the risk of reoccurrence after surgery. Repeat mammectomy is recommended, especially when symptoms return and you want to preserve your fertility. Yes, you can do mammectomy. Otherwise, if maybe you have completed your family size, it'd be best to just remove the uterus, because if there's a potential for recurrence, and going for surgery the third time may be very, very difficult. So repeat biometry is recommended for future fertility. Yeah. So there's fibroid. Somebody had fibroid during delivery,
Pregnancy, yes.
during pregnancy, and they're asking if it can continue to grow. Well, what usually happens during pregnancy with fibroid is that some of the fibroid degenerate, and degeneration is in different forms. It can be cystic, it can be fatty, it can be calcific, and this, when degeneration happens, means that the fibroid has lost its form and the potential for growth. So most of the time, the growth has stalled, then become calcified. When calcification happens, it means that the fibroid can no longer grow again. It's as if it's turning to a rock. It will just be there. It may still retain its normal size, but have reduced in size, but it will be there. You check back in 2 years, it's still there, same size. But there's a potential for newer fibroids to start to grow, especially when there is a long interpregnancy interval. So that's it. But some of the old fibroids may lose their form and may not be able to grow after delivery.
So another question around the symptoms. Someone says that what if the person has fibroid but hasn't started having any of the symptoms yet? What do you advise? I don't know if you've spoken to this, but
Hello?
we've had quite a number. Can you hear me, sir?
Yes.
Someone is asking, what do they do if they have fibroid but the symptoms have not started presenting? I'm going to tag you on the question, sir, so you can see it.
Okay. Okay.
Okay, I just did, sir.
Okay. I can't get the question.
Okay, so let me read it again. My question is, if someone has fibroid but hasn't started having any of the symptoms, what do you advise?
And that's what I mean. The expectant management, there's no symptoms. Usually, if a young woman is not ready to get pregnant and then she's not married, then you can still do expectant management, especially when there are no symptoms. But there are times the fibroid may be big already, but just that it's not causing symptoms. That can be readily appreciated. There may be some symptoms that you may not see on the outside. Somebody has a big fibroid that's already compressing on the ureter, and this causes backflow of urine to the kidney, and the kidney begin to swell, to enlarge, which can potentially harm the kidney. So in this case, there are no perceived symptoms, but then some other complications have started happening on the inside. So that's where the need for full evaluation comes in. So such person will have to be fully evaluated, then will have to get the advice of a doctor on what to do, especially gynecologists, going forward. So the symptoms may not all show immediately, or there are some symptoms you're already having, but you just assume it's something else. But when you are fully evaluated, then it become very clear either the fibroid is already causing some complications or not. So there may be need for further evaluation, and if it's not symptomatic at the moment, then expectant management can be done. Just watch and wait. Do routine serial regular scanning, maybe every 6 months to 1 year, to check if there's progress in the growth of the fibroid.
Okay, that sounds good, sir. So the person needs to go and see a gynecologist for the management.
Yes.
Okay.
Yes.
So I don't know if you answered this question around the movement of fibroids, if it's possible for fibroids to move.
Hello.
Is it
Hello.
possible for fibroids to
With us.
move?
And put on your
Is it
put on
possible
your
for
maybe it's my
fibroids?
network. Your own body.
Hello?
Okay, you're not.
Hello, sir.
Okay, please.
I can hear you.
I find it difficult to hear you. Okay.
Is it possible for fibroids to move upwards and downwards the abdomen?
Hello.
Okay, so because of network, maybe it's my network, but if anyone else can hear me, and if you have a question that has not been asked, please raise your hand so that doctor can take it, because he seems not to be hearing me. Okay. Gloria, you can unmute, please. Miss Gloria Udo. I have unmuted you.
Okay,
You
somebody
can
was
speak.
asking fibroid. Okay.
Yeah, Gloria Udo wants to ask a question. I've asked her to unmute. You need to accept the request to unmute.
Can I speak now?
Yes, you can. Please
Yes,
go ahead.
please.
Okay. My question is, does fibroid make movements like going up and down the abdomen? Does it move?
Yes, fibroid seems to be moving, especially when it's subserous, that is attached to the surface of the womb and is pedunculated, like is dangling, like I don't know, the bell, the bell, the church bell, the
Okay.
rod inside. So that's how pedunculated fibroid is. So anytime you
Okay.
move, it moves around. And the potential danger there is that over time it can get twisted and then start causing pain. So it may seem to be moving when you have such
Okay.
fibroid. Yeah.
Thank you, sir.
Also, even in cases where you don't have such, the uterus is enlarged. I mean, uterus, a non-pregnant uterus is more like the size of an egg. But now somebody has 5 week size. So it may also be swinging on the sides, really when there are no additions. So that can also happen. It's as if something is moving on the inside. So that most women come with that description, as if something is moving inside them.
Okay. I think that answers your question. Am I
Thank you,
right?
sir.
All right. I hope
Okay.
the question is answered.
Thank you.
Okay.
Yes, sir.
So,
Thank you.
Sri, you can go ahead. FY, you can go ahead to ask your question. You're muted.
Thank you very much. Good evening. Can you hear me?
Yes, we can.
Okay, good evening, Doc. Thank you for this session. Please, my question is, I've heard you say fibroids are big in size. So what size of fibroids are considered big? The last scan I did last year or 2 years ago showed that I still have 8 cm fibroids, right? And the locations are around I think it's called uterus also, but primarily, what size do you consider big?
Okay,
And
so
someone should start considering surgery seriously. Thank you.
okay, so when the fibroid becomes palpable, when you put your hand on around the lower part of the belly, usually below the umbilicus, then it becomes palpable, then it's already big. At that time it's already 12 to 14 week size. So it's already big. And you yourself, the patient or the woman themselves, will already know that something is there. You feel some pressure, and then at that time it's already big. But we have this description for each fibroid. Usually when the patient is around the navel or above the navel, then we say this is huge. It's already very big. When it gets to the level of the navel, the umbilicus. So it's already very big. But anytime when it becomes palpable, then the fibroid is becoming big.
Okay. Okay. So we also have Mr. Ifeanyi who wants to ask a question. Please, you can go ahead. I have asked you to unmute.
Okay. Hello, can you hear me? Good evening, Doc.
Yeah.
Thank you so much for this wonderful lecture series this evening. So what I want to ask is, just according to the lecture you give us, it says estrogen also increase the chance of a woman to have fibroids. So, and from this period, the number of women that have fibroids, because I know in the olden or in the past years, before a woman may have fibroids, age of 30, 35 and above. For this period, we may see some age 17, 18, even 19 years, up to 20 have fibroid at early stage. So what, as a health professional, what are the sensitization we also need to do so that to prevent this early, or to prevent a woman to have early chance of fibroid masses? So that is what I want to answer.
Dr. Rotimi, did you get that?
All right, thank you, sir. Can you hear me?
Yes, yes, we can.
Okay, so that we may need, well, like I said in the earlier part of the presentation, the risk factors. When patient has these risk factors, there is the parents or siblings, the mother had it, sibling had it, then such person or such woman should try early to start early evaluation for possible fibroid, because there's a higher chance of reoccurrence, of fibroid, in such person. So if there's a family history, there's need for regular checkup to see if there's fibroid, because early detection may also help in preventing some of the complications. Then we also talk about some lifestyle changes. The diet can be regulated, so we discourage soda, sugary drinks and all that are being implicated. Then also sensitize the community against obesity. Now we have a number, so we need to sensitize them, junk, eating that junk, then the food that we consume. We also need to ensure that they are low fat diets, then processed food, refined food. These are things that we should prevent, and we also need to promote healthy lifestyle, people to eat high fiber diet, fruits, vegetables, and to avoid red meat. Then fish, especially those with omega-3 fatty acid, has also been said to be preventive. Then supplementation with vitamin D, especially in areas where it is deficient. So this may go a long way in reducing the risk of developing fibroid, especially at a young age. Then, as much as possible, we should promote the health of the girl child. So generally, then screen for polycystic ovarian syndrome and all those that may also have some effect on their fertility later in life, as well as prevention of sexually transmitted infection, which may also affect their fertility and invariably delay their conception. So these are things that we can do in our community to prevent the growth or reduce the growth of fibroids in the populace. Thank you.
Thank you, sir. Thank you. Fantastic. Speaking of diets, there was a question around, do you need to change your diet completely if you have fibroid, especially rice?
Okay, so you don't need to change your diet completely, just to modify. And what we advocate is balanced diet. You need a proportion of carbohydrates, protein, fats in your diet, fruits and vegetables. So we promote balanced diets. We should eat in the right proportion, not to eat as if we are eating for 3 or 4 people. So eat with moderation. And then we should avoid refined food. A particular food was mentioned when I was trying to check some of these, which many of us actually take. So you should avoid some of these refined foods, processed foods. So these are things that may increase the incidence of fibroid.
Okay. Particularly in our climate, diet is very important. Thank you, sir. So I think one final question we have, if anyone else has before we, or from what I can see, is what about painful menses on the first 3 days alone of the cycle? Pain that affects the daily life activities. Is this normal? Then does someone take
Okay, so painful menses.
Does she
I think
take
I've talked about that. But then painful menses, there are other things that can cause painful menses apart from fibroid. So part of that is endometriosis, adenomyosis, even pelvic inflammatory diseases in some cases may also cause pain during menses. Then fibroid may also be a cause of pain during menses. So there's need for further evaluation to be able to know what in particular is causing such pain. It's not normal. If you have to take drug during your menses, then it's abnormal.
All right, sir. Then someone is asking about the treatment options that the hospital offers. I would think this is case specific, but you can go ahead and answer, sir.
Which one is that, sir?
What treatment options does Mother and Child offer for fibroids?
All right, thank you. So for that, at Mother and Child Hospital, which is a center of excellence for women health, we have different types of treatment for fibroid. We have the expected management in cases where it is necessary. We have conservative management. The medical approach is readily available on consultation with the gynecologist. Then we have the conservative surgical options. One, we have hysteroscopic mammectomy, which is fast becoming popular. And we have laparoscopic mammectomy for selected cases. And then we have open mammectomy, which is more like the traditional approach to the management of uterine fibroid. So these are the high-level treatment options that we have at Mother and Child Hospital. And in cases where a patient has choice for other methods, such as the uterine artery embolization, the HIFU, the other radiofrequency ablation method, patients are evaluated and based on findings are referred accordingly to Center of Excellence where these procedures can be done. Thank you.
Thank you, sir. I'm not sure if you've answered the question around doctors are suggesting surgery even though this fibroid is not very big, but they are multiple. Have you answered that, sir?
Please come again.
She says that if doctors are suggesting surgery, even though the fibroids are not big, but they are multiple, should she go for the surgery? She's not ready to conceive in that she's not yet married.
Okay, so
Married.
well, I believe if a doctor has assessed a patient and determined that patient will require surgery, either is like I've said before, even if it's a tiny nodule or fibroid that is causing problem, there may be need to go and remove it. A woman has a tiny fibroid nodule within the endometrium and is causing profuse bleeding, menstrual bleeding. So you won't wait and say, oh, because it's tiny or because it's small, so just go and leave it. So you need to remove it. So at any point when there are symptoms, you might not even need to consider, oh, you are not ready to get pregnant, you are not married. But since there are symptoms that affect the quality of life of the patient, then you need to remove it. Even size, it may not be big. We've had instances where we remove up to 88 fibroid nodules in a patient. But if you look at it, they are like peanuts. When we put it inside the bowl, they are like peanuts. In fact, we have to leave eventually because removing everything will mean like removing the whole uterus. Because they are just like pellets, everywhere, just removing everything. And the uterus was not very big, but it was causing some other problems for the patient. So it's just the treatment approach includes the symptoms. The symptoms, the fertility desire, and then the quality of life of the patient. These are things that are put into consideration. Thank you.
Okay, that is very clear. I believe there's one more question I'm not sure you've answered around what it means when fibroids calcified.
Okay, so calcification of fibroids, as the word implies, is deposition of calcium compound on the fibroid nodules, wherever it's located. So when you remove such fibroid, it will look like stone. It will be very hard. You can't press it. It's the soft or the firm consistency of fibroid is lost. It will look as if it's rock. So because it has degenerated, then became necrotic. But the body generally find a way of containing it, and then you now have calcium deposit from different parts of the body, coming to, make it become calcified.
Okay.
So it will be as if there is bone, yeah. The color around it, even when you look at it, it's as if it's a round or ovoid bony structure. And calcium is an important element of bone. So it's deposited on the fibroid nodule. And this may follow after delivery.
Okay. All right, that's very clear. I think the final question that just came in is, what drug can you recommend for heavy menstrual bleeding?
Okay, for heavy menstrual bleeding, there are drugs we can use, such as tranexamic acid. We have the hormonal treatment, the progestin can be used to control bleeding. Then for patients who have very serious bleeding, we need to go as far as using GnRH analog to reduce the bleeding or stop the bleeding for a period, and then where the patient will be prepared for definitive treatment. These drugs are just to manage. They won't take away the bleeding overnight. Over time, maybe the fibroid shrinks, it may reduce the bleeding. Or in some cases, these drugs are given in preparation for definitive treatment, other treatment that will give more alleviation to the problem.
Okay. Thank you so much, sir, for all the answers and for a very wonderful presentation. At this point, if there are no more questions, if you have any question, you can still raise your hand. But we'd just like to also thank you for joining today's session. Our Mother and Child Hospital is based in Lagos. We have locations. Okay, she wants you to type the name of the drugs for
Okay, so
menstrual bleeding.
drugs cannot be taken just like that. So there will be need for evaluation by qualified medical practitioner, maybe gynecologist, to determine if these drugs are necessary. We're just giving it out for educational sake. So we can maybe meet after the presentation, then can have some further evaluation to see what the patient or whoever needs it may need.
That sounds good. That sounds good. Thank you very much. Thank you everyone once again for joining. We are in Omole and Ikeja, Lagos. We're a multi-specialist hospital. We also have a fertility clinic for those who are on the journey of parenthood, who are trying to have their own babies. You can follow Fruitful Field on social media. The link is in the chat. We are on TikTok, Facebook, Instagram. You can also visit the link there to download the brochure and learn more about the services. We have experienced gynecologists in the house if you need any form of support. You heard one of them speak earlier, and then we also have Dr. Rotimi, who has led today's presentation. So thank you very much for joining. We look forward to having you at our next webinar series. Please do well to follow Mother and Child Hospital on social media. We are at motherandchildhospital.ng on Facebook, Instagram, and also on LinkedIn. You can also follow Fruitful Field _ or Fruitful Field, MCH Fruitful Field Clinic on Instagram, Facebook, TikTok. Thank you very much, and we will see you at our next session. Have a good evening, everyone, and it is bye for now.
Thank you.